I'm going to go through this. The first part of this talk is kind of our standard shoulder instability talk, and at the end, if you can stay awake, is when we'll generate some discussion and some of the things that I think are potentially going to change how we treat shoulder instability. So when you talk about orthopedics, really should start with the basics of anatomy, talking about really what are we dealing with and what is it that we have control over. So in the shoulder, you can separate both of these into two broad categories of static and dynamic anatomy. Static are those that really we cannot necessarily change other than in the operating room. The laxity we're born with, the capsule ligament, the labrum, et cetera, those are the things we're fixing. Dynamically speaking, the rotator cuff is what we're working on in physical therapy. So the static restraints, and the one that we speak of most often is the inferior glenohumeral ligament. That's the one that is most often injured because the most often direction of dislocation is anterior and inferior. So the analogy that we are all taught in med school and then residency is the hammock. Now I've seen cartoons with a different drawing and I could never quite understand what the hammock analogy meant until I saw this one. And so if you look at this, there are 4 points of fixation of the hammock, and likewise anterior, posterior, attachments to the glenoid and the humerus. And if at any one of these 4 points you have disruption, you have instability. And so anterior band of the inferior glenohumeral ligament is, anterior is your Bankart, posterior Bankart. Anterior would be a humeral avulsion of the glenohumeral ligament, or Hagel. And then there's the posterior Hagel, or what was it that you wanted to call it? Can't recall. So the glenohumeral ligaments have different jobs at different degrees of abduction. So at 0 degrees of abduction, the superior glenohumeral ligament is the main restraint to anterior stability. At 45 degrees, the middle glenohumeral ligament takes over, and at 90 degrees, the anterior band of the inferior glenohumeral ligament is the main static restraint to anterior translation of the humeral head. So the glenoid labrum provides the attachment for all capsules and ligaments. It has really very little bony contact, and only 50% of the stability, the bony stability, comes from just the glenoid. The labrum increases the depth of the fossa by 50%, dramatically increasing stability. The bony restraints, as I mentioned, the glenoid, pretty small. In fact, the analogy we again use often is the golf ball on the golf tee. And so there's really not much stability that comes from the bone alone, but any loss of this bone on either side dramatically affects the stability of the joint, and we're going to get to this later. But you can imagine, those of you who golf, a very small amount of a chip off the edge of the golf tee will cause you to throw that golf tee away because it doesn't work anymore. Dynamically, there are multiple factors. The most often and most important talked about would, of course, be the rotator cuff, long head of the biceps, negative intra-articular pressure, and the fluid cohesion effect are really minor players in the dynamic stability of the shoulder. So it's of paramount importance whether we're talking about treating these things through surgical means or non-operative means that we have balanced muscular forces across the rotator cuff. Could be a talk all in and of itself. So the categories of instability include multi-directional. Examination generally is going to show hyperextension of joints, most commonly elbows, the wrist. This is the ability to habitually, or at least voluntarily, dislocate the shoulder. You've got to beware of these patients. These are patients that need rehab. These are generally not surgical patients, and you do have to consider the potential that they have something like a Marfan's, or in this woman's case, she has Ehlers-Danlos syndrome, and when she came to me, she had not surprisingly already failed 2 soft tissue procedures, as she shows you how to rotate her hand 360 degrees. So posterior instability is often delayed, often missed. This variable labral pathology, it's seen in an athletic population on a chronic standpoint, but it does need to be differentiated from multidirectional instability. Traumatic is caused either by dislocation or subluxation. Atraumatic generally is going to be in that category where you're trying to distinguish between an MDI and somebody who voluntarily dislocates. And then the subset of those people are those that will habitually dislocate their shoulder versus just say, hey, can you get your shoulder to come out of joint? Which is different than someone who all day long is just popping their shoulder out the back, because that person is going to end up with a rounded posterior glenoid, and that glenoid bone loss is going to be a much harder problem to attack. So the mechanisms of injury, direct and indirect, seizures, dashboards, electrical injury, and of course offensive linemen are those that have posterior instability. Posterior laxity is tested with the arm in forward flexion, internal rotation, and adduction with a posteriorly directed force as shown here. So an acute posterior dislocation with bone loss, what do we do? Well, if there's less than 20% of bone loss in the humeral head, closed reduction and splinting can be effective. Once you get to 20 to 40% humeral head defect, or a reverse Hill-Sachs lesion, as we'll call it, generally you've got to do something surgically to restore stability to that shoulder. Either bring the subscap into the bony defect in the anterior aspect of the humeral head, or do some sort of posterior stabilization procedure, potentially a posterior bone block if there's bone loss posteriorly, and oftentimes a combination of all of those. Chronically posterior dislocated shoulders are bad actors. If they're able to be reduced, they can be treated very infrequently non-operatively. Most often you are looking to do some sort of an operative procedure, again, to put that subscap into the defect, address the posterior instability. And for those that have a large defect, more than 40% has always been the number that we talk about doing an arthroplasty. Although in a younger patient, you can consider an allograft, or now we have hemi-caps of varying sizes to fill the deficits in those younger patients. Inferior instability is pretty rare. It's less than 5% of all dislocations. I've seen maybe 1 or 2, but when it does happen, it's fairly dramatic. And you've heard of the too many toes sign, and this young man has the too many hands on one side of the body sign. It generally means things are not going well. So the most common is anterior instability. Can be subtle, as in there where he dives with an arm that is forwardly flexed and externally rotated. Oftentimes it is not nearly as subtle, but it's generally an excessive force to an externally rotated arm. It will create a spectrum of injuries, Bankart lesion, etc. As you just saw on that weightlifter in Beijing. So apparently, amongst all the other ancient Chinese secrets, closed reduction of shoulder is one that they don't want to share with the rest of the world. So the clinical evaluation, the provocative maneuvers are the drawer sign, anterior and posterior stability or instability as compared to the other side. For me, this one is one of the more sensitive in my hands, which is the apprehension. I'll do it lying down so that the scapula is stabilized. I'll follow it up immediately with the relocation test. And this almost always, in a classic anterior instability, is going to provide some relief for the patient. Examine under anesthesia is the gold standard, and for the fellows who are here now, it's hard when you're running around between rooms to get in there, but this might be the most valuable part of the case for you at this point, is the ability to truly test the static stabilizers of the shoulder with the patient completely relaxed. And oftentimes your exam is under anesthesia is going to change what you do, or how you approach anyway what you're about to do surgically. Evaluation with radiographs, obviously x-rays, there's multiple things that we're going to look for, but typically we're looking just for a concentrically reduced joint and the potential for bone loss. An MRI is going to show the classic Bankart lesion with disruption of the anterior labrum, and sometimes an avulsion of the periosteum going down the medial aspect of the neck. So what about non-operative treatment? So mobilization, classically internal rotation, arm in a sling. There is no real consensus on how long they're supposed to be in the sling. There's now even debate on what position their arm should be in. And so these older studies talked about anything from 1 week to 3 weeks. Was it dependent on age? Was it dependent on regaining range of motion? I think most of us would say 2 to 3 weeks in a sling and start working on motion, but it's really all over the map because the science doesn't really back one treatment. So immobilization in external rotation, as Itoy showed us back about 14 years ago, is better in external rotation. So if you look at the picture on the left there, that is an anatomically reduced labral complex with the arm in external rotation compared to with it in internal rotation. Okay, and so he did a study where he looked at a whole bunch of people varying ages and put them in these abduction external rotation splints and kept them there for closed treatment of their instability, and showed no recurrent dislocations in the patients who were immobilized in this position versus 30% in internal rotation. And actually it was even worse in the younger patients in internal rotation. And so that was a hot topic about 12 years ago until they started following these out. As most things in orthopedics go, as you start to follow out your results in longer terms, you start to think of things differently. So with this study, they showed that there was in fact a pretty high recurrence rate. It was better in external rotation, but it was 26% versus 42%. So who's going to be happy with 26% redislocation rate? Nobody. Hence surgical treatment. So the surgical treatment can be varied at this point. I think the gold standard is arthroscopic stabilization, but there are factors to be considered. Age among them, previous surgeries, contact athlete, level of sport, etc. Expertise of the surgeon. There's really a lot of factors. The goal is to reestablish normal anatomy. If it's easy as reestablishing your normal classic essential Bankart lesion and an acute injury with no bone loss, that's a slam dunk. If it's a posterior lesion, again, if it's an acute issue with no bone loss, that's also a slam dunk. But there are times and places where we will generally go back to the old school open treatment through a delta pectoral approach. So how is that addressed? Well, delta pectoral approach, identification of the subscap, take the conjoined tendon and the pec medially, and you either split the subscap as is shown here, or you can actually do some sort of a partial or complete tenotomy to get to the capsule and the glenohumeral ligaments. You have to, in one way or another, get to the detached labrum, which is pretty low down, and so this is a little bit more challenging than you'd think. And I know that you have the benefit of seeing Dr. Andrews do some open shoulder stabilizations. That's rare, rare, rare in this day and age. I did a fellow course last year. It was towards the end of the fellowship year. There were 70 sports fellows in the room, and we asked how many had seen an open shoulder stabilization. And I think other than our fellow who was there, 2 other in the room had seen one during their fellowship. So this is a dying art, and it probably is going to make a comeback for reasons that we're going to get to later. But once you identify the labrum, the idea is to do the same thing we do through the scope and repair it anatomically. You then can imbricate or tighten the looseness of the inferior glenohumeral ligament by doing some sort of a laterally based repair. Results were good. 0% to 13% in many studies, good to excellent in most, but throwers did not do well. The return of throwing was limited by loss of motion in these players. So that became one of the reasons to really looking into doing this arthroscopically, and there are many advantages to doing this. Less pain, less morbidity, less risk of over-tightening, potentially other issues, but really it's this top one that is the real reason that we should be doing these arthroscopically, because we can see better, we can identify other pathologies better, and we can treat them all at the same time. So there are numerous studies showing this. Snyder was one of the first to do a large retrospective review of his patients. He found these fairly staggering numbers of associated pathology: 29% with at least partial thickness rotator cuff tears, 11 with full, 22 with slaps, and so on. What are the disadvantages? Well, you cannot address bony defects to some degree. I think that, you know, that 20-25% number is tossed around. We've all seen acute bony Bankarts that are less than 20%, and you can do that fairly, easily these days with the different instrumentation that we have. But once you get to large bony defects, especially chronic ones on either side, it's going to be hard to do anything through the scope. Can't address glenoid hypoplasia or reversion problems, pretty rare. Don't have to worry about it. Humeral avulsion of the glenohumeral ligament, I think that probably deserves a question mark at this point as a disadvantage, because there are some that you can do through the scope. I've done a handful. It's not easy, but it's doable. Certainly technically challenging, and potentially high recurrence rates were disadvantages as people were getting better with this. The early arthroscopic results were horrendous. These are master surgeons, and if I had the chance to ask them if they were in this room why they kept doing this with, I mean, Gilles Walsh is an unbelievable shoulder surgeon, and he had 49% recurrence rate. But they kept with it, so here we are, and obviously these results got better over time. Cole did this study showing pretty good results, good to excellent with a scope, not quite as good as open, but getting there, about the same in terms of satisfaction and return to play. But this wasn't a very good study in terms of its design. And so as time marched on, there were other studies. What about arthroscopic versus non-operative? So this study looked at 40 patients under 30 who had a first-time dislocation, and after more than 6 years, there was really no difference in functional outcome. However, there was a higher rate of dislocation. And so I suppose you were happy because you could do things if you were treated non-operatively, but you might have your shoulder just pop out randomly. I don't know how patient satisfaction was scored in that study. Here's another one by Osiero looking at a straight-up prospective study of non-operative versus arthroscopic Bankharts. 75% of the non-op treated had recurrent instability versus 11% arthroscopically. So not only is it clear in this study from 13 years ago that arthroscopic beats non-operative, but those numbers started to approach that of open and started to become the gold standard. We started to get better at it. We knew more about which patients needed to be done arthroscopically, shorter OR time, and about the same failure rates as open. Recently, of course, these numbers continue to improve, and without a doubt, it's the gold standard. Here are some more recent studies looking at retrospective recurrence rates, all in the single digits. The thing to understand about these studies is that most of them have less than 5-year follow-up. As we start to go out in time, okay, longer follow-up. In this study, I reviewed 26 studies with a follow-up of mean of 11 years. The numbers are still pretty good. They're approaching, I'd say, about equal what open is in terms of its recurrent instability, but the numbers start to creep up at about the 5-year rate. So what about in contact athletes? Well, contact athletes do not have as good results across the board. Why is this? More often than not is unrecognized bony deficiency. So there are dozens of peer-reviewed articles that agree with this concept. It's estimated that, as in this study, more than half of the failures are not necessarily due to technical problems by the surgeon. It was simply an unrecognized or unaddressed bony defect. So these can be significant on both sides. We tend to kind of look at and not worry too much about most Hill-Sachs lesions, but depending on where they are, in addition to how large they are, and potentially a combination of both, they can become significant. And that is if they engage. So this is the mechanism. Shoulder dislocates out the front, have an impaction injury of the posterior humeral head from the anterior glenoid, and you're left with this little deficit. Well, if that little deficit can never get there because you've fixed the labrum, then really it's of no consequence and you go on happily ever after. But if it engages, you're going to have recurrent instability. The real question is, can you address all Hill-Sachs lesions simply by doing soft tissue procedures on the glenoid side? And the answer, of course, is no. So there's new thinking on this topic, and the more common or the more modern thinking now talks about on-track and off-track lesions. And we'll get to that study in a little bit, but what we're really talking about is treatment with a remplissage. And so this was first described by Dr. Wolf, 2002. It's a French word meaning to fill a void. and that is all you simply do arthroscopically, is you drop an anchor directly into the defect to fill the void. Functionally, what you're doing is you are decreasing external rotation by moving the edge of the rotator cuff from there, moving it medially all the way, well, here, or even all the way to the edge of the defect. So glenoid bone loss, what's significant? Again, the 25% number seems to be the one that we throw around the most. Acute injuries are fairly straightforward and amenable to arthroscopic means. The Segoya technique, there's a Preventure technique, they're all about the same. And you are lassoing this bony piece generally by placing an anchor either somewhere close where you lasso the piece around, or there are techniques where you can actually put an anchor here and an anchor here and do a tension band fixation of that piece. It works fairly well. It's fun to do, and it's particularly in an acute case where you have that piece of bone pretty easily freed up already. So in chronic cases, the inverted pear glenoid, there's an unacceptable risk of failure in these patients, as shown in multiple studies from multiple high-volume surgeons. The failure rates, again, are the highest in the contact athletes. And so successful treatment for glenoid loss, instead of really talking about open versus arthroscopic surgery at this point, I think we can agree that arthroscopic surgery is probably the gold standard. And what we should really be asking is, can we do it through a capsular labral repair alone, or do we have to do something about the bone loss? And so absolutely more than 25%, you've got to do something about the glenoid bone loss. That you can do free grafts, iliac crest grafts, allografts. The distal tibial allograft is looked into by Matt Preventure as an interesting concept, but the more classic and certainly more commonly performed are the coracoid transfer procedures, the Bristow and the LATARJET. So the LATARJET procedure, what is it exactly? So it works in 3 different ways. So there is a bony effect. You take a chunk of bone and you're putting it on the front of the glenoid, and you're just basically increasing AP diameter, which is going to make it harder for that humeral head to come out the front. There's a ligament effect. Okay? So the technique described by the French will tell you to leave a piece of what is the coracoacromial ligament attached to the coracoid, and when you finish your repair, you can tighten the capsule by doing a little bit of a suture to that stump of the CA ligament. And that's the second effect. And finally, the muscular or sling effect, that effect of the inferior 1/3 of the subscapularis, as the arm swings up into abduction, it actually tightens and holds the bottom of the humeral head in its place, keeping it from dislocating. One thing to consider while I have this picture up, so this is the inferior 1/3 of the subscapularis. The position of the bone block is important because obviously it needs to fill a defect and you want to be increasing your diameter. But the lower this goes in this direction, the lower you are pushing the inferior 1/3 of the subscapularis, and what lives right there is the axillary nerve. And so if you go too low, you're going to have a higher incidence of axillary nerve palsies in these patients. So the horizontal split through the 2/3, 1/3 of the subscap is performed openly, at least in this country. You decorticate the area for bone-to-bone healing of the bone block that you take off from the coracoid. So 2 parallel screws, cannulated or uncannulated, depending on the system you use, are all that is needed to provide compression at this area. It provides a benefit of fast healing. So this is bone-to-bone healing. It happens in 6 to 8 weeks. This is not something that takes 6 months to recover from. And a lot of surgeons in other countries are letting their patients go back to play rugby much earlier than we would let our patients go back to contact sports, because they're satisfied with bone healing by 2 to 3 months. In terms of the position, this study was a nice biomechanical study that talked about the ideal position being that 4 o'clock, 8 o'clock position for the bone block. And again, the lower position increases the potential for axillary nerve palsy. So here's where you have to start paying attention, and what was enlightening to me. When you look at the results of recurrent instability of these patients, the numbers are dramatically low. 1% in 1,000 cases, 2%. 13-year follow-up with 1.4% recurrence rate. So, obviously they're now 8 years into doing this arthroscopically, which is akin to a magic trick in my eyes, but they're obviously doing so many of these that this is becoming the procedure of choice for almost all shoulder instability cases. And one of the knocks that I remember from residency learning about the LATARJET was that because you were basically shoving a piece of bone into the glenohumeral joint, that you potentially were going to increase the incidence of osteoarthritis down the road. Well, the French have followed out their patients for as long as 20 years, thousands of cases, and what they've found basically are the incidence of OA at 13 years and then again at 20 years is mild and essentially the same as what you're going to see in the treatment of any other shoulder instability. So I think that potential concern has been debunked. So everyone now is thoroughly confused perhaps about what really should we be doing. What's the indication for a remplissage? So this is that on-track, off-track consideration that Burkhardt described last year. There's another paper that talks about the glenoid track being 84% of the diameter, and there's a lot of math involved, and if you can't measure this arthroscopically, this red line here, you can go from the bare spot, which is to the posterior edge, which is the radius multiplied by 2, blah, blah, blah. Don't worry about all that. The concept is this. If what you have left on the glenoid, whether it's native glenoid or a glenoid with some bone loss, if the red line is smaller than the blue line, then you're going to have potential for an engaging Hill-Sachs. The way they measure this, and it's an arthroscopic measurement, is you measure from the edge of your rotator cuff insertion to the most medial portion of your Hill-Sachs lesion. So if the Hill-Sachs lesion is the whole thing, or if it's just half and it's just a little one over here, the measurement's the same, because it's that external rotation in this direction where this part of it, the leading edge, is going to engage. And so he will essentially do a quick measurement between how much glenoid do I have, how far medially does my Hill-Sachs go, and if he thinks it's going to engage, he does a remplissage, which is a very quick procedure for those of you who haven't done it. It's straightforward. It's 1 to 2 anchors. You're looking right at it through your posterior portal. So what's the indication for a LATARJET? It is as simple as defining 25% bone loss, or potentially, as I just mentioned, is it more than that? Well, this is what Below has come up with. Okay, his indication was a retrospective analysis developed looking at thousands of patients who were done, and he went back and looked at their preoperative activities, their history and their examination, and stratified them into a scoring system, which I'll show you in a second. But you can see that the scores above 7 have a 70% failure rate. Okay, not acceptable anywhere. The scores below 3 had less than, or had about a 5% failure rate, which is as good as any study that's out there. And so how do you figure out who's got 7 and who's got less than 3? So the Instability Severity Index score, which is unfortunately these days shortens to ISIS. Not sure if Pascal is going to change that or not, but so he looks at the age of the patient, 20 or less, 2 points. Is the patient a competitive or recreational or a non-athlete? Is there a contact sport? Now, notice that the contact sport's only 1 point. Competitive nature of the athlete turned out to be more significant in his retrospective analysis. So hyperlaxity was a point, yes or no. He defined hyperlaxity as greater than 85 degrees of external rotation and adduction bilaterally. So like that woman that I showed you in the video who could externally rotate her elbows about 150 degrees, obviously hyperlax. And then looking at both sides by plain x-ray, because he wanted to develop this system without having to rely on CAT scans and MRIs if you didn't have them available. So he used plain x-rays, which just about everybody can get. Plain AP x-rays. If you can see the Hill sacks, it's large enough to warrant concern, 2 points. Same thing with glenoid bone loss. So this is, so I went to his course in Nice last summer, and this was a course of about 850 shoulder surgeons. These were not all Frenchies. And I went in there thinking this is just going to be talking about LATARJETs because that's all they do. Maybe 120 of them were French. The rest of them were completely international. I think there were maybe 3 or 4 dozen from the US, but it was a broad spectrum of surgeons from all over the world. And they had one of these things where they asked a question and everyone hit their key little remote button that's on your seat, A, B, C, D, and then they show the answers. And you're always in the majority, or you hope you are, and you feel good about yourself. So this is the question they asked. 18-year-old rugby player with no bone loss, first-time dislocation, how do you treat? And the choices were non-operatively, open bank heart, arthroscopic bank heart, open LATARJET, or arthroscopic LATARJET. And so I, of course, put arthroscopic bank heart, contact athlete, 18 years old, no bone loss. That's an arthroscopic bank heart in my hands. I was in the minority because 81% of the room, no one wanted to treat it non-operatively, and 81% of the room was doing either an open or an arthroscopic LATARJET. That split was probably 2/3, 1/3 to open and arthroscopic. So all of a sudden, I started to feel like this. Oh, are we missing the boat? Is there something that these French surgeons and other international surgeons have figured out by looking at their recurrence rates long term that would make us start thinking about doing more bony procedures? It's hard to argue. Obviously, they have a point of view that's not necessarily shared with everybody, but they have a fairly significant mountain of data. And so I thought of it like this. If I put any stock into Pascal Below's ISIS score, every high school football player in this country starts at a 5 before you even do an examination or take an x-ray. And so they are already halfway to that 70% recurrence rate. Basically, if they have any hyperlaxity, if they have any bone loss on either side, that bumps them up above the threshold where he would expect an unnecessarily high risk of recurrence. That's every high school football player and half of the college football players. So, the conclusion, consider the bone loss, consider the athlete, and our long-term recurrence rates trending towards treatment with LATARJET. So thank you very much. If any of the fellows ever have an opportunity to go to Nice, it's a beautiful place and it's really a fantastic course. So, any questions? Are they crazy, Dr. Andrews?
No, I was in France and Lyon with LATARJET and Paul Grandma who developed
Reverse.
And Europeans, particularly the French, anything they do from a surgical approach is twice as big as anybody can do over here. It's always been that way. They have a bad result. They can march in to see the professor and the patient sits down their foot up and thanks them for whatever they did to help them, and they dismiss them. They hide their infections from the chief of surgery, orthopedics, send them off to a work rehab hospital. He never even knows about the infection or some complication. So it's a whole different concept. And their patients are different.
Right.
People accept scar that long. Over here it's entirely different.
Well, now they're all doing them, or learning to do them arthroscopically as well. So, but you're right about the patients being different. I mean,
Over here doing it arthroscopic.
I'd say a select few.
think anybody's doing. Anyway, 2 years ago when we had combines and we had college kids coming in that day were all defensive backs. We had 5 college kids come in from major universities that were done by very, very good team physicians that had LATARJET procedures done in college. And 4 of the 5, of course we x-ray everybody, 4 of the 5 had disruptions of the screws and the bone block. One of them had a screw all the way down here almost to his elbow in subcutaneous tissue. Maybe that's a learning curve, but there have been a lot of people in the NCAA schools and the professional ranks are staying away from LATARJETs, even though they say they do it in all these rugby players everywhere. That hadn't been accepted here. And for them to have 85% of a first-time dislocator,
right.
In the United States, that first-time dislocator in rugby or football would be treated non-operative and reassessed when the year's over with. So it's a big, big difference what goes on, what's accepted, what's not accepted. I don't know who's right, but obviously there's a big overzealous treatment of shoulder instability with LATARJET procedure. You didn't talk about the complication rate. Just about everybody in the United States that's done a LATARJET procedure has had a musculocutaneous nerve go out. And there have been more axillary nerves go out than musculocutaneous.
I'll look forward to that on my next one.
Huh?
So I'll look forward to that on my next patient.
Okay.
What is your indication? Obviously, just bone loss.
I wouldn't do it on primary if somebody was just ordinary like that case. I would have said probably, my answer's not up there because we probably would treat that kid non-operative in the United States until the season's over with, unless it was a pro. So the answer doesn't match what you really do. But what you said, the lower you got
the bone block,
the closer you were. Tell us that again. You said 4 to 8.
4 o'clock. So I'm going to go back to the picture.
You said 4 to 8. That's the all the way across the bottom.
So, well, either depending on right or left is what I meant. 4 or on the other side it would be 8.
Just talk about
or 7. So, right. So this is a picture of
that's the lower quadrant, right?
Lower quadrant. But you can. It's difficult really to orient yourself when you're just looking through a little window in the subscap to exactly where you are, and so.
It's awful hard to get it low, though.
If you end up putting it here, which isn't very different than here, you're down and you're just, basically the further you push the soft tissues, the subscap, or whatever it is in that inferior window, you're going to put some tension on that axillary nerve, which is coming, in a 3-dimensional way from this direction and sweeping under, but it's going to be pushed down by the subscap. So the lower you put the block, the higher incidence of axillary nerve palsy.
I think that what I saw at some sports medicine meeting, wherever it was, when what's his name from Boston was talking about it.
Matt Preventure. JP? Warner?
JP. Maybe it was Shoulder Elbow Society. Their big problem that everybody was talking about was injury to the axillary nerve and closing was to put traction on it. You got to watch the musculocutaneous nerve though. It varies where it comes into the muscle of the biceps, of course, and your whole biceps can go out and transfer that nerve. They transfer that forward.
Yeah, we always talk about 5 centimeters distal, and when I harvest the bone block, you can see it, but it's not always 5 centimeters, and sometimes there's a branch closer.
It varies where it comes in. You're stripping it down, trying to get it so you can get enough to put that down in there. You got to have it's got to be stripped off to go over the top. particularly the big, heavy, muscular kids, so it's not easy.
No.
Let me ask a question. Roger, everybody. If you're doing an arthroscopic bank card routine, similar to that picture you showed in there earlier, put in 5 anchors in front of the shoulder. 3 months later, the suprascapular nerve to the infraspinatus is completely gone. It's out. Big hollow place back there. How could you get that from that surgical procedure?
The highest anchor was for a bank card, so you weren't doing a slap. A very errant superior anterior portal, but it'd have to be really very errant.
Anterior portal? What if I said the patient also had a brachial block?
That'd probably be more likely. I've seen that.
What do you do when it's 3 months before it shows up?
That's precisely when I saw my patient who had it.
What do you have?
Well, he had a slap, and I saw him 3 months out.
You get the suprascapular nerve across the glenoid.
Right, and so that was.
When you put those anchors in, you're not going back that way. You're aiming into the central part of the glenoid itself. I know Steve Snyder talked about that, but that's almost going straight into that notch here.
Well, that would. Right.
How would you get it? Where would it have to go?
You'd have to be high up here. Yeah, you'd have to either be shooting up or just be high. But in the patient I saw, I got EMGs, I'll get an MRI. I thought perhaps I did it when I fixed the slap. And then just the EMG showed that it was from the block.
Superior glenoid realm is not like that glenoid right there. Or is it? It's more where we did.
It's probably more.
Not way around the back. Where that shows that thing is more. Well, that would be 9, 8, 9 o'clock or something, right? What's the spine scatter?
Yeah, I would think it's probably more like that.
Not that far back. Or does it? I'm just asking. You know, when we decompress it, right up here at the top, where we see the nerve, we have a cyst or something.
I would agree.
Did you say you had an infraspinatus out?
Yeah, completely out. Supraspinatus was okay.
What'd you do?
Well, I got an EMG that basically pinpointed that it was upstream and from the block, and the MRI was normal. And so we watched and waited, and over the course of about 6 months, it came back. Here's another picture. That's a little closer to where the biceps is.
You said on your score, hyperlaxity meant greater than 85 degrees of external rotation. And then you showed it doing it down here. Is that what it is?
In adduction. In adduction. Yes, elbows down.
Yeah. I didn't say that on your slide, but that's what you meant, huh? What's normal external rotation down there? How much will your arm go? I don't think they ever measure it down there. Well, the pictures are all hyperlax, most of them. So they probably have more external rotation from that, plus they have retroversion when they're kids, if they throw when they're kids. So their external rotation is sometimes going all the way to the floor. But nobody ever checks them down here basically when we do range of motion, unless you're trying to do that
scoring system.
What you call it?
I wonder if they would have more down here. I mean, we know they all have
slide up. Here's another question. And you showed it in one of your slides where you were putting anchors in. Go back. Let's see. Yeah, right.
Which
You showed it when you actually had a arthroscopic bank art being done. I want the fellas to look at it. Yeah, right here. One of the things that we're noticing is that, and we need to study this if we possibly can, what is the incidence of a Buford complex in the normal population? I know that's been done. Steve Snyder, I think, did it. I can't remember the percentage. Anybody remember?
it's relatively high.
Academy, damn it, I can't remember what I found.
Yeah, it's relatively high.
I think it's
20,
much
25.
higher in growers that have a lot of external rotation. That's the reason they're bred into it. Genetic. They can externally rotate more. We're also seeing that in linebackers and football players. We've had several this spring, since football season's over with. And what you got right there, you see that labrum coming up? I bet you if you looked over that, there's a hole right there on the other side of that little old labrum. So the capsule stops down there at the anterior band, the inferior glenohumeral ligament. And sometimes you don't have any labrum up here. It's almost
kind of rolls off the edge.
Nothing to put back. But what do you do when you see that arthroscopically and all you got is those two anchors down here in the most anterior and inferior part of your hammer? And you don't have any capsule, this big hole up there, and this little labrum is just nothing or a little strand like you see right there on the right hand side of that picture. What's your failure rate with that situation? Are y'all seeing that? We've had it a bunch of times this fall, where we just don't hardly have anything to put back. And we try to close off, pull the middle glenohumeral ligament end up a little bit higher, where it comes in almost all the way up by the biceps anchor. You pull it in a little bit to tighten it up. You can't pull it all the way in.
Do you do that in your throwers as well?
Well, it depends on how loose they are. If they're a thrower with a dislocated shoulder, we're not doing it on throwers that are not, if they have a slap, we're not doing it. But if they dislocated their shoulder, we're trying to figure out how we keep them coming at it. But I'm just saying, when you have that, it's a mess. And that's basically what you see on that picture right there. Do you know where that picture came from?
I don't.
It looks like one I had.
It probably is.
With it.
It's in a
behind that's a hole.
library of videos.
But anyway, it's a problem. Do you have what was done after that anchor was put in? Is that the end of it?
I think if I go
all
deep.
you're going to do is put that back. You put that labrum back on, what good it does.
Yeah, I don't know that I have that work going all the way up. Looks like another one.
That's why, for example, go back to that part right there. When you start debriding that and stripping it all the way off, sometimes you do more to harm than good unless it heal low. The one that with not much to put back.
It's sort of a trend thing that probably isn't necessary all the time, but if you get one that's marginal and you're not real, happy with the repair or the tissue's not great, and you consider the footprint response, you can do that.
I just wonder what 2 years later does that really heal back? I don't believe it does, but I've never done one either. And I worry about it.
For what it's worth,
they wind up doing with those things. You wind up blocking their external rotation. That's what the problem.
20% bone loss in the glenoid, and I was debating whether to
see how that's been stripped off? Everybody tells you should strip it off so you see the muscle belly down below of the subscap. I'd be careful doing that when you got loose tissue like that. You wind up you don't have much. It seems to destroy your continuity of your tissue when you strip it off that much. See how it's been stripped off? That may be. I believe that's what we did, as a matter of fact. But it doesn't have very good tissue.
Yeah.
sit in the room and they say,
That's the print, I'm telling you.
how do you argue with 5 to 8% recurrent rates from arthroscopic back or no complicated surgery?
I mean, obviously, in some ways, it's everything. If you have a hammer, everything's a nail. And I'm not standing here saying we should all be doing what they're doing, but I'm telling you that I was shocked because
I
it
don't
wasn't
believe
all
their
French
results,
surgeons.
but
I mean, we're talking Australia, all of Europe, the Middle East, China. The entire world was represented in some way, and we were in the minority.
when they talk about those results you showed over in France, when I was over there, they didn't. Their results are different than what they're not as accurate. I just don't believe it. What did you show? 1% recurrence rate or something?
That's actually an American study out of Texas. But yes, there were several. I think that was Brad Edwards out of Texas had that study.
Right here.
Yeah, that was.
Bolaya's over, your guy over there.
Well, these are French, but he's in Texas. He went. Brad Edwards.
You know where Brad studied?
In France.
No kidding?
Yeah.
You know who his daddy was?
Probably below or Wall.
Daddy was a fellow with me.
Oh, his real daddy? I don't know who his daddy is now.
He went over to
I thought you meant who's his daddy.
year with them, and he came back hot and heavy about everything they did over there. He's a good surgeon.
Yeah.
Brad Edwards. He's over in Houston. But his daddy was Tom Edwards, who was a tree farmer. Got killed in an airplane crash, but he was one of my early fellows. He initially was a high school football coach. His daddy. And that's Brad. And Brad's a real enthusiast, but he's honest. So if he's getting a 1% recurrence rate, it said reviewed 1,000 cases. What does that mean? He didn't do 1,000 cases. I
believe it was his first, however many, and he did review. I think some of them were probably Pascal's.
Yeah, he hadn't been in practice. In 2002, he was been in practice about 6 months.
He's a pretty busy guy.
He reviewed what Gilles Walsh, who he studied with, had done, and over in France. So that's a French study also.
There was a more recent meta-analysis like that. There was 45 studies, and their overall complication rate was about 30%. Their recurrent instability rate was close to 9%. They had corticoid non-unions.
Where were
like
in
9%.
France?
Well, looked at all studies out there that included, and
You're going to have a lot more than that in the United States.
Yeah, there's a lot of. I mean, it's a tough surgery. The malposition of the bone block. If you've got it too lateral, you're going to get OA. You're going to have, resorption of the coracoid. Excuse me.
You want to hear a story about LATARJET?
Dr. LATARJET?
Huh?
Sure.
He was a fellow when I was over there as a junior surgeon or whatever. Go back to his right there. Professor Triot, who's the one I studied with, he had a procedure he called wasn't a Bristol, but it was similar to a Bristol procedure out of somebody in Paris. And what he did was he went to the base of the coracoid process and made a little slit like that in the subscap. Did an osteoclasis at the base of the with an osteotome, the base of the coracoid. He bent it down. He put 2 Augustine boat nails in it. And it took him about 15 minutes to do the procedure. That's how good he was. And LATARJET was his stepchild over there. And he couldn't do anything right. Always had complications. So he modified Triot's procedure that was so simple and started taking it all the way off because he couldn't get it in position to drive those nails in. So he started taking it all the way off and putting 2 screws in it or something. But the reason he did it that way is because he couldn't do it the way Triot had taught him. And he was known to be a very poor technician. But then all of a sudden somebody came along and picked up on it and it became the LATARJET procedure. That's how things develop.
So you're saying I have a chance?
But it's not an easy procedure. Triot, the way he did it was just bent it down with an osteoclasis, drove it, and put a nail in it. 2 Augustine bolt nails that you drive in with a hammer. That was 1972. I did thousands of Bristos. We did Bristos for all the football players until Shoulder and Elbow Society came along. They all started poo-pooing, doing Bristos, because what do you do if you have to revise it because you screwed up the anatomy so much? And Charlie Rockwood didn't like metal around the shoulder joint, as you probably know. So they all said, you got to do an anatomic. Yeah, we did Bristos. We didn't even look inside the shoulder. We didn't have a scope. And so we all felt guilty about doing Bristos. And you ask John Burkfield, Bill Clancy, all those guys that came along with me. Bristow was a great operation. We had those. We didn't. Now it takes 6 months for somebody to halfway play. Back then with the Bristow, they played in about 2 months, like you're talking about. But anyway, we all quit doing Bristos because we felt like we were not doing we were distorting anatomy. And everybody quit doing them about 15 years ago and started doing what we call an anatomic repair, like those illustrations you showed a while ago. And that's why, though, we got pushed into from the podium about, oh, you can't do a Bristow. Not anatomic. Anyway, probably a big mistake. Now we're back to doing something even more complicated. We put 2 screws in it, take off more of the bone. But that's how things go in circles.
Still haven't heard how they revised the failed LATARJET either, so I'll have to go back.
Bill Clancy's doing a procedure where he takes the tendon off right there, leaves the bone alone, and sews the tendon into the glenoid face. And all you have is a sling procedure and no bone. So you just put 2 anchors in, sew it down, and sew it Weemy up. And y'all hear me talk about up in Washington. He did a biomechanical study, presented that, but that's Bill Clancy's original idea with no bone at all. Just the tendon of that, sewing it in. And the sling, in most studies biomechanically, is the reason that works more than anything else. And that's what they're doing. Some people are doing that with just tendon, which is a lot simpler. You don't use any metal. You don't have to fool with the bone.
They might call that the triad procedure now, because they may call that the triad procedure. It's been presented over there, the same exact thing you're describing.
Yeah, exactly. He called it not a Bristow. What was the other? 2 words that go with Bristow. The surgeon was from France. He's the first one that did that. Triad was always so particular. He never would call anything that he did by his name because he said somebody else has already done every procedure you try to invent. So he would always go back to way back and wouldn't use his name on anything. He's a great surgeon, though, I'll tell you that. Just like Fields Walsh and those guys, they're all good surgeons. Really good.
Yeah. All right. Thanks for coming.